Hello, everybody. Good afternoon and welcome back to CareNext Collective presented by Manulife Canada. Last month, we explored how patients are already using AI in their care journey. What became clear is this is no longer emerging. It's already happening, how people understand their health and how they show up to care. Today, we take a different lens. We are not focusing on what AI can do in theory or even what has the strongest evidence. We are focusing on something more practical and in many ways more consequential. What actually works, what actually gets used, and what actually changes care in practice. Because those are not always the same things. Across healthcare, we see tools with strong evidence struggle to gain traction, while others spread rapidly because they solve immediate operational or emotional needs. At the same time, patients are increasingly using AI, as we saw last time, outside formal systems to navigate uncertainty, to seek reassurance, to interpret information, and fill gaps between clinical interactions. So today's conversation really sits at the intersection of two realities: what health systems adopt and what patients are already using regardless. To explore that, I'm joined by two extraordinary people working directly inside those realities. So we are joined by Dr. Joshua Liu. Joshua is a physician and founder and CEO of Seamless MD, a platform used by hospitals and health systems to digitize patient care journeys through education, reminders, symptoms monitoring, and workflow integration. What makes Joshua's perspective particularly valuable is that he has spent years watching what actually happens when digital tools move from innovation pilots into real clinical workflows and operational environments. We're also joined by Ellyn Winters-Robinson. Ellyn's a founder of AskEllyn.ai, an AI-powered companion designed to provide psychosocial support to people navigating breast cancer. Built from lived experience, Ask Ellyn represents a different but equally important dimension of AI-enabled care: continuous emotional support, guidance, interpretation, and presence outside the traditional boundaries of the healthcare system. So welcome both. Welcome, Ellyn and Joshua. We're really happy to be joined by you today. So as ever, just a couple of logistics pointers. So we are, as you know, on a new platform, Teams webinar. We have enabled both the chat function and the Q&A function. We really invite the audience to participate actively. We ask you to use the chat for any comments, anything that you might want to share with us, and then we ask you to use the Q&A function to ask us questions, and we'll pull those questions in our conversation, which we are looking to make a very interactive one. We're also going to be involving you, as you might have noted in the last couple of sessions, through polls and questions. So perhaps we can begin with one. Carissa, if you wouldn't mind. We'd like to know what most influences whether a new technology gets used in healthcare. So you'll see the poll that Carissa has launched. We'd appreciate if you'd answer that, and I will bring in your answers. So yes, it seems like we're evenly split. Half of you are saying the workflow fit, policy and funding seems to be a big one, clinical evidence, patient demand. So it seems like it's evenly split between these. Thank you so much. Thank you for taking the time to answer our poll. So let's keep this in mind as we ground the discussion in real implementation and real patient behavior. I want to begin with adoption because healthcare often assumes that strong evidence naturally leads to use, but reality tends to be far more complicated. So Joshua, Seamless MD is now embedded across many health systems. What actually determines whether something moves from pilot to sustained operational use?
Yeah, if it's okay, I'll start with a quick painful story of how I learned this.
Please.
So over a decade ago, we found some great physician champions in Ontario, and this story happened at more than one institution where they said, "Hey, just bring Seamless here. We'll pilot it, and trust me, if we reduce readmissions or ED visits in half, I guarantee you the C-suite at the hospital will be on board. They'll invest in this. We'll scale it. It'll be great." And logically, to me, it made sense. Improve outcomes, you get adoption. And build evidence, you get adoption. And so we would pilot Seamless, and we demonstrate those results. We cut readmissions in half, and then we would co-present the results to the C-suite of the hospital. And the CEO, and again, this happened more than one occasion, would say, "Hey, great outcomes, clearly great for patients. Very happy to see this. But actually, given the way our global budget funding is provided by the government, if we save money on this by cutting those readmissions or ED visits, the government thinks that we don't necessarily need as much money next year. And so actually it doesn't really save us money. And so we can't really like invest in this." And we're finding this out like a year after having put all this blood, sweat, and tears into proving this improved outcomes. And so that was a big wake-up call for us. Now fast forward to like 2020, when the pandemic happens, and all of a sudden there's this urgency to get patients home and out of hospital safely and increase throughput through the hospital. All of a sudden, the government said, "Hey, this technology is a pretty good idea," and started actually funding hospitals to adopt solutions like Seamless. And so we went from like single digit like adoption among institutions to now being in about like 2/3 of major hospitals in the province. And it wasn't like the technology suddenly got massively better overnight. It's actually there was a crisis and a policy demand to adopt it. And so again, I'm an N of one story on this, but my experience has been unless there's demand from a policy and urgency point of view at a system level, it's really hard to make it a priority.
So I guess in that poll, you're squarely in the finance policy.
I admit to picking that one, yes.
In terms of getting Seamless adopted, how has your experience been inside hospitals, like once you were past that hurdle?
So I think we've learned a couple of things. So one is, people often say, well, you need a clinical champion. I've come to believe you need at least 3 champions from different parts of the organization. You certainly need clinical champions, because I've had cases where this got bought by a hospital because the C-suite loved it, and then we bypassed getting clinical champions, and they are really upset, and then it just failed. And so we're big on, you need a clinical champion to get the frontline staff motivated and mobilized and to put in the workflow. You need an administrative champion who actually makes it work on a day-to-day basis. And then you need executive champions who make sure it's aligned with the strategic priority and actually gets the resources it needs to succeed. And so you need all 3. And if you can do that, it goes great. If you miss even one of those, it can go poorly.
And do you see any difference in AI being adopted versus other type of digital technology?
Yeah, so I mean, lately, I think AI is on the minds of every institution. I think what's different even this time is I'm hearing from hospital leaders that they have board members telling them, "Hey, what are we doing for AI? What's the AI roadmap?" I'm not sure every year you're hearing, "Hey, what's our technology roadmap this year?" Maybe it was assumed that you had something, but everyone's asking about AI now, and so there's an appetite for AI. I think what we are seeing is that at least the first few years, most of the AI focus was on back office administrative stuff, low risk stuff that wouldn't cause patient safety or risk issues. Also, there was a big focus, as you know, on clinician burnout, and so things like AI scribes and some other tools that helped with operational workflows ended up having a lot more adoption initially. We are seeing more recently more of an interest now in patient AI initiatives, and we can talk a bit about that today as well. But initially, yeah, mostly administrative things that help the clinician burnout. That's where we're seeing the biggest investment right now.
Ellyn, Ask Ellyn emerged from lived experience and from recognizing that patients often need support long after appointments end. What are patients actually turning to AI for today?
Well, we certainly heard from your last CareNext discussion. So patients are going direct to the AI tools to essentially build their own, stitch together their own care journey. Because, there's patients that see different specialists or may even traverse between different institutions. And you see a very high use of AI in, for folks that have rare diseases, for example, where there's just not a lot of support and community. In my case, I think we just accidentally landed in this space that really is, I'd say, out of scope for most healthcare institutions, which is the psychosocial and emotional support needs of a patient, but also a caregiver. And it's that it starts the moment of a diagnosis when you're not yet engaged really with the system, and through into survivorship. And so that's the problem we're solving for. I always say because we're very strictly non-medical, we don't want to interfere with the clinical world. I always say I'm the parking lot tool. It's that, you go through a procedure, you have an appointment, and you go out to the parking lot and you either hit Dr. Google or you just have a big cry. And that's really where, and we have some evidence now that shows that for breast cancer in specific, that that physical symptoms in survivorship, that psychosocial and emotional distress are equally high. Like they're literally dominant in terms of what people are expressing. So so there's definitely some work to be done there.
What does Ask Ellyn provide that traditional care pathways struggle to provide consistently?
Yeah, it really is that it's really a surrogate to a peer support system. That's what I've been to many healthcare conferences at this point, and really the system looks to peers to provide that companionship, that emotional support. And not every patient feels comfortable engaging with those support groups. I know personally, when I was diagnosed 4 years ago, the first thing I did was join a bunch of Facebook groups, right? And immediately found that I was in a spot of collective trauma. I was scared, they were scared. It just was it was very alarming, and I had to retreat from them quickly. And then there's other cultures who may not feel comfortable engaging with support mechanisms, or may not want to speak truth, or don't feel comfortable speaking truth to power or asking questions to the clinicians. And so that was a real aha moment for me, because Ask Ellyn speaks every language, to know that maybe there's a woman who's very ashamed of her diagnosis, or her family is very ashamed of her diagnosis, and that I might be the only friend that woman has.
Well, I can, from personal perspective, when I faced a cancer diagnosis, what repelled me off of groups is that I did not want that to be part of my identity, right? And so something like your technology would have been very helpful. So we're seeing kind of two parallel realities emerge. One is organizational adoption, what systems approve and fund and integrate and scale, and the other is behavioral adoption, what patients are already using because it meets an immediate need, and those realities are not always aligned. What becomes increasingly important is where these realities collide inside actual care delivery. So Joshua, how is AI-enabled care actually showing up in clinical environments today?
Yeah, so a couple ways. So I think just jumping off the patient conversation, I think most patients are using consumer purpose AI tools in different ways in their health, and that's leading into conversations with the care team. So, I know myself, like my wife and I, like we just had our first baby, and gosh, we're using every tool out there to answer questions.
Yeah, they don't come up with a handbook.
No, they don't. Yeah, that's right. Yeah. That's right. This baby's gonna be raised on ChatGPT, but we use ChatGPT, use Gemini. Now I'm using the clinical tools like Open Evidence and Doximity and UpToDate and all these things. I'm using everything. And on the one hand, it definitely answers a lot of questions that I otherwise would maybe have wanted to go in to see a clinician for. On the other hand, obviously, it's creating more questions that we bring up in the actual clinical visit. And I know from colleagues who are practicing that it's been good and bad. And I think in cases where the patient is more health literate, and has more background in the way that, like, luckily, like myself and my wife both came from the clinical world, we have a bit more experience with it. We can more safely interpret some information and kind of filter it. But a lot of folks, don't have that same background, and so they're coming in with a lot more questions and concerns that need more time for conversation. And so I think my big belief now on the clinical side is that providers have to invest in actually helping patients, not just understand the output, but actually help them learn how can we prompt these tools more effectively. I think the cat's the bag. You can't tell them, hey, don't use this, it might give you a bad answer. It should be, hey, let's share with you some useful practices to make sure you're getting relevant, contextually useful answers, and then let's talk about what you're hearing. But it can't be like, don't use them. I think that's a big mistake.
Yeah, I actually said exactly the same thing at a conference recently, that, let's acknowledge that patients are using this, and let's help guide them. Let's give them those prompts, just like you would have a clinical workflow to follow. There's various diagnoses that I think could have prompt behaviors so that patient can become a better patient.
And then from clinician side, Joshua, what do you see showing up in their practices?
Yeah, so I think one of the realities when it comes to adoption is even though at the end of the day we're all patients and we all would love to, at least I would love to see more safe AI use among patients, the lowest hanging fruit has been AI tools that help clinicians do their day-to-day better. So we've talked a bit already about AI scribes that automatically document the note, but besides that, I think the other big one we're seeing is actually clinical decision support tools, or I mentioned like Open Evidence and Doximity, GPT. Like, for those who don't know, these are basically AI medical search engines where in the past a clinician may go to a tool and like type in a question and get like an encyclopedia of information. Now they go into these tools, they type a question in natural language, and they get a chat GPT like response of medical information that is based on evidence. And so I think what the neat thing is that there's probably a lot of questions that a clinician now asks and gets more information to take care of the patients faster and easier today that maybe in the past they wouldn't even try to. Maybe in the past, like, it would take too long to get this answer. I'll just tell the patient what I know. Now it's, actually, I can put my phone, type in my question, and hopefully get let's say, get Ellyn a better answer in the moment than I otherwise would have had. So I think it's decreasing the friction, just getting better medical answers to patients.
So now you have patients arriving with their AI briefs and clinicians using similar tools. So where do you see potential for alignment and or tension? And this is a question to both of you, perhaps Joshua, if you want to start, and then Ellyn, I'd love to hear your perspective on this as well.
So I think one of the interesting things that we're going to see start happening is, you already had the clinician saying, hey, I'm going to have my AI scribe to record the visit and document it. We're now seeing some patients start to use their own AI scribe, right? And say, hey, I'm also going to listen and document because I want to make sure I can take away the information too, right? And got your recommendations, my next steps and all that. I'm also I've heard stories where some of the clinicians are saying, oh no, I don't want that because I'm worried about like what's being documented. And so I think we're gonna have to figure out, and by the way, I get why there's always concern about like liability and like, oh my God, like where's this documentation going? So it's a little bit controversial, but I get it. As a patient, like, well, you're recording me, why can't I record the visit too? Like, yeah, like why not, right? So I think we're gonna have to figure out together, okay, like how can we make this all work? Because ultimately both parties I think are well intentioned and both can not have to spend time taking notes and can go home with the best information that was discussed. Like, that's better for the patient, it's better for the healthcare organization. So can we make dual scribing work? I think that's a big question we're gonna have to figure out together.
Yeah, from personal experience, before I hand it to Ellyn, when I was going through my cancer diagnosis and treatment, my oncologist, this was way before we had scribe technology, but he would allow me to record our sessions, and
Yeah.
it was intensely helpful because you are living this massive, massive stress in your life. And to be able to retain all the information while you're sort of coping was very difficult. So it was very helpful to be able to kind of go back to it. And also you're in this state of intense fear. And so, you know, what you're hearing on the first might differ from what you might hear when you re-listen. So it's very interesting. I did not realize that patients were also resorting to scribes. Ellyn, your perspective on this.
Yeah, I mean, I did the same thing, Danina. I mean, you know, I now find myself in the AI world. When I was diagnosed 4 years ago, I wasn't using AI, but I was doing the same thing. I was recording, you know, with my surgeon's permission, the information that he was telling me. I have voice recordings of it because, yeah, you're in cognitive overload, right? So you're just, your ability to retain knowledge in that place of stress and trauma is you know, really not great. So you know, look, I'm a patient who has very much drunk the AI Kool-Aid. I see. So let's talk about burnout for a second. So if we can resolve that, as a patient, I'm going to have, you know, there's going to be a hospital that's going to have doctors and nurses that are available to me when I need them. And the other thing is that if we can unburden clinicians by giving them tools to make their lives better and more efficient, well, that's more time that they're spending actually looking me in the eye. And, you know, it can free up more space in those visits for real, genuine conversations and to be able to answer those questions. So that's one thing I see. The other is that, you know, I always say the healthcare system understands this concept and talks a lot about this concept of shared decision making. And I always say that nobody kind of lets the patient in on that. And so to me, the fact that, you know, we have now tools available to patients to rehearse for conversations, to make sure that they go in with the right questions, to be able to interpret what is being said to them, to be able to, you know, I won't say dumb it down, but one level simpler so that that clinical language is at least, you know, turned into human language. You know, that now we've got it, you know, equal parties at the table, you know, and you know, I turned to things like Dr. Susan Love's breast book, which I read from cover to cover and did all this research, but not everybody has that ability or will spend that time when they're scared out of their mind. So, but yeah, I'm excited about the fact that if I can feel like I'm a colleague, you know, not a non-clinical, but an active participant and an equal in the conversation, that brings back a little bit of agency and empowerment to me in a situation where I'm feeling really utterly out of control.
It sounds like it's a relationship that very much requires trust. I mean,
and transparency. That's level one.
Exactly.
Level one is consent and transparency.
So how do we build that? Same thing. Question to both of you. Maybe Josh, I'll start with you.
Yeah, I mean, I can share what's worked for us on the seamless side as an example. So we actually recently released our you know, first like AI conversational AI for patients. And so just for context, Seamless provides, like, we call it digital care journeys, but essentially it's a platform used by hospitals and health authorities to guide patients through something like, let's say, you know, pre and post surgery. And so as part of implementing that in the pre-AI world is we'd work with the hospital and the clinical teams to customize the instructions to match what they are telling patients. So for example, if you're going to have a surgery done, you might be told, stop your blood thinners a week before surgery, stop eating at midnight, here's the exercise to do when you go home, here are the symptoms to monitor. And we would digitally help you do that on your phone or on your desktop. And then in the AI world, what we've done is said, hey, we have all of this approved clinical content and instructions that your care team is asking you to do anyways, let's say throughout your surgery. Let's layer on an AI model using, you know, retrieval augmented generation, or RAG, where basically we're saying, hey, we're only going to give you an AI answer to a question based on the information your care team has already approved. So that way, if you ask us a question, we're going to give you an answer that your care team would tell you and not what Reddit or the open internet is. And an example that I think illustrates this is if you've had, knee replacement surgery done and you go on ChatGPT and you say, hey, when can I take my bandage off? ChatGPT will say, oh, the consensus answer on the internet is 1 to 2 days after your surgery. But at a lot of hospitals in Ontario, you get a special bandage where actually you don't remove it for 10 days because it's meant to protect it for 10 days and then you take it off. And so if one of those patients now goes into Seamless and types in, when does my bandage come off? It tells them 10 days. And it actually, to Della's points around trust and transparency, it even says, hey, by the way, here's the educational page from your hospital that you can read for more detail that tells you also it's 10 days. You know where it's coming from. And so I think this has really taken off in Canada, even because we're saying to the healthcare providers, hey, we're not going to give you a patient AI tool that's going to conflict with what you're telling patients right now. Actually, it's grounded in what you're telling them, so everyone's aligned. And that surprisingly has been a big reason why adoption has been, it's new, it just got launched in the last 6 weeks, but adoption has been quite good.
And is it even between clinicians and patients? Would you say that this approach also works in building trust with patients, Joshua?
I think so. I mean, I think part of it comes down to do patients feel like the source of the information is something that they feel comfortable with. So I think and so here's the thing, I'm an N of 1 patient, so for me, I care about the source. But I think what's interesting is that if you ask ChatGPT or Gemini a question, very often you don't get a source. But if for some reason that you've built trust on it from other ways that you've used it, in some ways you might blindly follow it for better or for worse. So I think, it makes me think, well, actually, in that case, it's even more important that we find a way to make sure that we know the source of information, or that like in Ellyn's case, you have a trusted, companion that patients can feel like, okay, this is coming from somewhere credible. Because it is easy to just go to ChatGPT and assume it's correct. And I think we've all had cases where for things that we're knowledgeable about, we realize ChatGPT is wrong. But for the things that we're not knowledgeable about, we go, oh, it sounds right.
Yeah. Ellyn, your perspective on this from patients.
Yeah. Again, I think, that there needs to be this conversation about trust and transparency. So, I've seen posts from doctors who, find their patients are clamming up when they turn on the AI scribe. So I think, part of it is just making sure that there's this agreement between the two parties that if they're comfortable, then, like I think if a patient is wildly uncomfortable about an AI scribe, then you might have to go back to the old school to be able to maintain that trust. Another interesting sort of, I've become involved. There's an organization out of the US called the Light Collective that is looking, and they have actually developed a patient rights initiative around AI that's really looking at where is patient data going as well, and so that it's not, because people are going, I'm actually pretty uncomfortable with going to like a ChatGPT Health or a Gemini Health where they're inviting you to upload your records. But I think Alvina talked about this. When you're desperate, you want answers, and so you're going to do it. And it's like, but we have to, we have to make sure that patients understand that they're surrendering their data to a technology company in this case. And so I think we were talking at the top of this about, you've got healthcare providers, you've got patients, you've got clinicians, you've got policymakers, but there's also the tech players that also now are a stakeholder in this as well. And so it's just, I think there's work to be done there. And I think we just want to always make sure that the patient is very actively involved in these innovation discussions. And hospitals need to be thinking about, or providers need to be thinking about the governance, so they can give their clinicians appropriate guidance on how to have conversations with their patients and how to establish that trust. It was interesting. I was just at this conference, an AI medicine conference, and we were on a panel, and the doctor that I was sitting beside asked the room if those clinicians had read their provider's consent policy. There were not a lot of hands went up. So,
so to that point, Joshua, what does responsible deployment of AI look like to you?
Yeah, I guess part of it depends on what type of AI that we're thinking about. But I think a couple of things. So on the provider end, you need good. I mean, it's funny when we hear the word governance. I think the initial reaction is like, oh, that's going to slow us down. But I think the more I learn, I think about what it means to have good AI governance on the healthcare organization side is actually it helps you speed up, because if you can set clarity in the team on like what the principles and the guardrails are, what the expectations are for safety and testing and monitoring the AI tools and the models in case it drifts off, and all that, it actually helps you move faster because you have clarity in the team for what's okay. So having good AI governance in place is really critical. I think it's really important that as any digital tool, that you have good clinician buy-in feedback, that it solves a real problem from their perspective too, that fits in the workflow. It's easier than ever before to build AI tools or any technology and then not have good adoption. So getting that clinical workflow integration right is important. But I think even more important, to Ellyn's point, on the patient side, when it comes to trust and transparency, I think we have to be able to educate clinicians on how do you talk to patients about these AI tools, right? Like you can't just say, oh, it's like ChatGPT. Like that doesn't mean anything anymore. You know, that's too vague. You have to explain, hey, here's what the tool is for, here's the purpose, here's the benefits, here's the risks. You have to give patients the chance to opt out of things like this. I think Dallas' point is like, look, a lot of patients will be okay with the AI scribe. There are going to be some who aren't. You shouldn't try to force it. You should recognize that everyone's a bit different on it, and maybe over time they'll change their mind. Maybe they won't. It's okay. But you have to respect that. And so, but it starts with actually good education, because there's probably a lot of patients who, if you just spent the time to explain things properly, they may actually be on board, whereas without explaining it, they wouldn't be. So I think you have to explain it, but I think a big thing missing is just the training. Like, how do you train staff to talk about AI and understand it and educate patients on what this actually means? I think that tends to be missing, and I'm not sure if folks are investing enough in that.
What does that look like? And this question is to both of you from your individual perspectives. Maybe Ellyn, start with you. Like, what does that training look like? What is that?
I think Josh is right. I think it's first starts with an acknowledgement that it's not just the clinicians that are using AI, that patients are using it. And I think it comes down to, again, providing patients who ask the question of patients, are you comfortable with me using AI? Are you using AI yourself? And again, can I help guide you? I remember when I was first diagnosed, I always say I felt like I had just been enrolled in Cancer University. There's all this terminology that was getting thrown at me, and I was just so bewildered. I never even thought about getting breast cancer, and so a tool like this would be, and so that's a very safe way to say, look, you can use an AI tool to help you understand, the terminology and the types of breast cancer, and so it's things that are sort of adjacent to the clinical world. And I also know that, again, in the case of Ask Ellyn, so many of my questions, I had great care at RAN, great care. And I saw every tube, every hospital in the system. And I never was mistrustful of the medical care that I was getting. But the other questions I had nothing to do with, they were all lifestyle related things. I had a double mastectomy. I wanted to know if I could do a chest fly ever again. I wanted to know how fast my hair was going to fall out. I have one story of a woman who reached out and thanked us for what we built. She was taking her bandages off after a mastectomy and having a shower, and she was dealing with seeing her scars for the first time. And so the ability to talk to another woman who'd been through it made it very relatable. So I think it's, just as it is on the patient side, there's going to be degrees of comfort and familiarity with using these tools. I think that's the same in the clinical world. But I also think there's a lot of young doctors that are going to be coming along that are going to be very eager to use these things. And so it's just about really responsible use on both sides.
What do patients need, Ellyn, that clinicians often underestimate?
The psychosocial and emotional support, like that, the burden, the emotional burden that comes with a diagnosis, not just for the patient, but for the caregiver, is as I say, it's out of scope, and it is a real blind spot. I just recently spoke at a conference with GE Healthcare and spoke to an audience of radiation oncologists and shared my story about being bewildered and scared. And, as I was going through this imaging work, and they were coming up to me afterward, just shocked. They're like, I didn't know how scared you were, because patients we're not breaking down. We know we've got a very limited amount of time in front of our care team. And so we're just like focused on trying to, hear what they're saying. But believe it, I'm 4 years out. I just started seeing a trauma therapist because survivorship is hard. You've got drug side effects. You've got, at least in breast cancer, there's double-digit issues around partner abandonment. These are things that doctors don't, know. And the other thing is, once you're discharged from treatment, you go from, the system basically owning you for 300 days. And then you go into survivorship and they're like, bye, see you in 6 months. And you've got Stockholm syndrome. It's crazy. I mean, Danina, you're nodding. You probably understand this very well.
Yeah. In many aspects, the period after was a lot more difficult than
way more difficult.
No, it sounds counterintuitive, but
I'm very attached to the gong.
And I have a serious case of PTSD. Like everything that I work for and advocate for, I don't apply to myself because of what I had been through. So yeah. So one of the themes emerging here is that care increasingly extends beyond encounters, right? Patients don't stop needing support when the appointment ends.
And that's not, I think the system can support that, but they can't deliver it. Like, let's be real. I mean, even the best, system with a great navigation program still disengages when that patient, goes out of active treatment. And, and the first, so I heard I had cancer from my family doctor in March. I didn't see a surgeon and have a biopsy at Freeport until early April. And I lost 10 pounds in 4 weeks. I couldn't breathe. So again, the system is blind to all of that. And there's really no supports for caregivers. So we all know in Cancerland that, people say absolutely the worst and wrong things all the time, And so that's part of the scope of Ask Ellyn, and part of our scope of our clinical trial is to be that coach for family members, because they're also on the trauma bus and lost.
I would say the other thing for me is that clinicians are increasingly interacting with patients who are continuously informed, who are supported, and who are influenced by digital tools. Let's kick it to our audience with another poll. Where do you see the biggest gap today? Carissa, if you wouldn't mind launching that for us.
It's on its way.
Thank you. So you'll have a couple of options: what gets adopted versus what is needed, patient needs versus systems response, workflow versus technology, evidence versus real world use, and emotional support versus clinical care. So while Carissa is setting that up for us, if we want to better alignment between what works and what gets used, what actually needs to change? So maybe Joshua, I'd start with you.
Yeah, so this doesn't sound obvious, but it's a really hard one. We've always struggled with aligning incentives in our healthcare system. And so when I think about how, I think it's great that we have AI adoption for these back office and documentation and workflow tools. I mean, I'm like Ellyn, where I think AI can be great for patients, and I wish there was more AI adopted by institutions, not just for not just even just for AI for patients to use, but even just more AI tools that help directly improve patient outcomes, right? So, for example, in the US, one of the biggest use cases in AI is how do we get the healthcare insurance system and prior authorization and getting testing and procedures approved in man, we're spending like our efforts to go to AI to make the insurance and billing system more efficient. Like, what about AI to improve direct patient outcomes, patient care? And I think unless we can improve policy and the reimbursement models to actually prioritize, hey, actually, if you take better care of patients, you'll get paid better. It's going to be hard to get adoption of these AI tools that have a bigger direct impact on patient care. So it's a tough one. We can't just, it's hard to wave a magic wand here and improve that. But I really feel like if we want to see the value of AI help patients more, we does need some change in policy. It's a tough one.
Yeah.
I mean, I'm really, say I've been exposed now. I actually thought that a lot of these AI medicine conferences would go right over my head. And instead, I went away like so stoked because some of the research that's happening and some of the projects that are being implemented, like, things that we wouldn't even think of. There was a presentation by, he's an anesthetist out of Oregon who's working with Google, and they've created an algorithm for the iPhone that actually detects AFib, like not AFib, sorry, a sudden cardiac event, and that will actually, and it's a whole bunch of layers, but it will call 911. And that, so that's saving lives. There was a presentation by an oncologist who's using AI that they basically they can type different types of breast cancer in very, very quickly. So they're saving on lab costs. They're able to get a diagnosis much quicker, get that patient into care much quicker. So those are all really super exciting opportunities. There's a company out of the UK, actually heard her present. She's using AI to improve OR efficiency and unlock hidden capacity. So again, all of those things may seem operational, but they actually really move the needle in terms of patient care. So those are things that really, that's where I think, my ask of the system is to move from level one, which is sort of how we do what's manual today and do it in a more operationally efficient way, to let's start to imagine new, like, things that you think are unsolvable today. Can we make that leap and start to look at how AI can be deployed to solve problems that really matter?
So treating it like a strategic resource that it is, rather than just tech, right? Something that allows you to rethink how things work entirely. Our audience is agreeing with us. Most people believe that the gap is in patients' needs versus systems response. So, question from the audience that seems kind of pertinent to what we're talking about right now. Asif says, I was reading this paper by Google DeepMind where they developed a framework called AMIE for diagnostic medical conversations. Since we are seeing AI agents move beyond simply chatbot style responses toward more structured clinical workflows, how do you think AI agent-based workflows will realistically play out in healthcare?
Yeah, I actually know that research team. I was just with them in Puerto Rico. And actually the lead is here in Toronto, which is kind of cool. So yeah, they're working with Beth Israel down in New York. So they actually have something in clinical implementation right now with the AMIE project. And yeah, so these are all things that, again, acknowledging that our resources are thin and that patients need support, and I think, think back to, like, even if it was an AI agent who called me after I had my chemo and just said, how you feeling? Like, just to me, this opportunity to extend care using technology is, I think, so cool.
Joshua, from your perspective, what operational capabilities are missing to fully embrace AI?
Well, operational capabilities. It's interesting. I don't think a lot of the embrace has to do with technical. I mean, let's be honest, like, AI is evolving so quickly that what's technically possible is going to continuously outpace what we end up deploying. I think that the biggest thing actually is AI fluency and literacy. And I think that's true across every stakeholder group, right? So, we talked a bit about, if we could make every patient more AI AI health literate, meaning they not only are literate with AI tools and the limitations and the benefits, but also that in the healthcare context and raise health literacy and AI literacy that will make AI use, more safe and effective for patients. But even on the healthcare organization side, on the provider side, most organizations are working to improve AI literacy. Not everyone is bought into using, even just like general purpose tools yet in their work, right? Like whether it's Claude or ChatGPT or Gemini. I know we've talked, Danina, I think in the past that even in Canada, it's hard to even get these tools in organizations, right? There's a lot of complex procurement going on, even to just get like general purpose AI tools to help your staff become AI native. And so I think it's really important that we make it easier for healthcare teams to even just learn to tinker with AI tools, because the moment they even figure out, hey, actually AI improved my workflow or my day-to-day in this one way, it helps them realize, oh, this actually can be useful. And they start to imagine other ways in which they can improve not just their workflow, but how they care for patients. But you need that light bulb moment where it's like, oh my gosh, like it did this. Okay, like if it could do that well, imagine what it could do for all these other things. But you have to create those magic moments, and that only comes with exposure and literacy and training. And so I think if we start there, it's like give people opportunity to tinker and use these tools in organizations, train them on it, educate them on it, and then let them like run with it. But we can't skip that step. We can't just like hand them the tools even and say good luck with it. I think like my thing is like find some really great use case for each business unit or department that gets them excited, that makes their day-to-day that much easier, and then see what happens when they realize what's possible.
Yeah, there's actually a really interesting initiative right now at Princess Margaret. It's called the Blue Coat Project, and they're going to be recruiting actually students to just go in to the hospital and work with researchers and clinicians and help them become more AI literate and conversant. So it's kind of cool. Yeah, so some of my friends at Princess Margaret were posting about that. The other thing I think operationally that needs to happen is, and I think we have such an extraordinary opportunity here in this community as we build this innovation hospital, is we have, I mean, the system looks at patients. I always say I'm the most impatient patient ever, because patient means suffering in Latin, and I am doing absolutely not suffering. But this opportunity for patient innovation, let the patients lead. They see the gaps. They will bring you problems that you don't even know exist. Let them in. Right now, I think a lot of innovation happens inside the hospital, and there's just an element of, self-interest that happens there because that's their world. And then they bring in patients to react to whatever that innovation looks like. But what if we flip the script, right? And again, I'm pretty sure in Waterloo Region that there's a heck of a lot of patients who are mechanical engineers and people with lived experience and computer scientists and people like me that are just relentless, that would absolutely love to participate in that kind of initiative. And I think it'd be eye-opening. And I think we could solve a lot of unmet problems.
Couldn't agree more, and happy to say that through the work of CareNext, we do invite patients deeply. Let me push on this a little bit, Ellyn. If we designed healthcare around how patients are actually using AI today, what would look different?
I think we'd move from that efficiency mindset to the reimagining mindset. I think that we would be the system. Maybe that would be scary. They'd be exposed to all these things that are the realities of going through care that, are just completely blind spotted. But I also see that there's very simple things that I think we could do that would improve one's care journey inside and outside of that treatment window. So yeah, I have a grand vision. I want to move beyond breast cancer. I have cancer advocates and disease specialists, as long as my arm, who want similar AI companions. So we've touched on something here with Ask Ellyn that is clearly an unmet need. So that's just one example, but I do think where we run into problems is when you start inviting people outside the system, inside the system, or try to adopt things that are happening outside the system into the system. There's a bunch of like walls and barriers that healthcare puts up, right? Like rightly so. It's got to look at patient protection. It's got to look at the risk. There's a clinical evidence requirement. Funding is hard for these startups. I see so many startups in the work I do as a mentor at the Accelerator Center who have brilliant ideas, who get so close and they die on the vine because they can't get funded. So, and Josh, I'm sure you've lived that reality, so you're kind of on the outside looking in. So, I long for a day where, how can we bring these parties together so that they can learn from each other, and help those startups understand what it takes to really get technology inside.
Joshua, similar question to you. How should leaders think differently about AI readiness?
Yeah, I mean, I kind of I jumped to Ellyn's point about the reimagine piece. I think many healthcare leaders are ready for how do we just use AI to squeeze out that extra bit of efficiency. So like, yes, I think AI scribing is great. I think it's great that we can automate documentation. I think it's great that we can use, teams to like record and transcribe and meetings and automate all that. I think that's great and necessary. But to Ella's point, I think AI creates this opportunity to really like have the tools to reimagine like how things should be done in the first place. So for example, why do you need to document as many things as we require people to document? Like, do we need every little bit of detail that people currently do? Or is it that the encounter is recorded and then on the user interface, depending on who is looking at that information, who's asking, is it a patient, is it a cardiologist, is it a family doctor? The AI just displays the most appropriate, contextually relevant summary or answer to that stakeholder, instead of giving everyone the same original note and having the patient parse through this specific clinical note that, like yes, you could tell AI, please turn it into a patient-friendly thing, but it's probably going to miss some things the patient cares about, right? Because we're still having the clinician choose what to include in the day in their version of the note. And so, if we can reimagine what's possible and build that future in an AI native kind of healthcare system, I think we'll unlock so many different ways of doing things. I mean, even in the non-AI world, look at telemedicine, right? All we did was we digitized the clinical encounter. We just added a video. But if you just like stop thinking about it that way and said, hey, actually, if we wanted to reimagine what the ideal virtual experience is for a patient, it's probably not what telemedicine looks like.
It's agreed.
Sorry, go ahead, Ellyn. Yeah, you're gonna.
No, I'm nodding violently here in terms of it. It was something we heard in Puerto Rico as well. I think we're at an inflection point right now with healthcare. We know it needs to change, right? No, there's no primary care physicians. The system is really, really straining. And, we can use technology to kind of automate already what exists, or we can use this as an opportunity right now to zero base and to build from the bottom up something that is radically different, that is, and built in a collaborative way with patients. I'm so excited at the potential that, and there's big, like this was Harvard University and this was Mount Sinai, and these were all the big players that were in the room here. And, that's the thing that really, again, as the patient in the room, one of the only patients in the room, that was what really excited me, was let's just wipe the slate clean,
Let's put our futures hat on. From both of yours perspective, what will be completely normal in 5 years from now? What do you hope will be completely normal in 5 years from now?
Okay, so I'm going to start. I think we will have, and I had this conversation with Dr. Gipp from GE Healthcare. I think that there will be clinical digital twins. I think that would be really cool, where every clinician could have a digital version of themselves that is sort of acting as like a resident that would just kind of be always there for them. I think every patient will be using AI, for sure. It will be part of every conversation. I think we'll be past I hope that patients' rights are and their rights to their data are more transparent and better used. And I really hope, you touched on it, Josh. I was on this panel with a woman who and her weaponized AI and denied her father care, and her father died. And so I'm hoping that AI doesn't just become this arm of the evil beast, and that because that's going to create huge hatred and resistance.
Well, Josh is answering a same question to our audience. If you wouldn't mind putting a sentence or two in the chat, what will feel completely normal in care in the next couple of years? Josh, your perspective?
Yeah, a couple of things come to mind. I mean, one is I think AI will be so embedded in different parts of the healthcare system that we probably won't be talking about AI in the same way that we don't talk about, the internet anymore in the general sense, because it's so embedded in connectivity in the internet and healthcare. We don't have to call it out. I think AI will be the same, where we don't need to call it out as, are you implementing an AI tool this year? That's not going to be a conversation in 5 years. Something that's maybe a bit further than 5 years, but I think we'll start to see happen in 5 years, although not ubiquitous, is you're going to see some clinicians who actually become like orchestrators of let's call them medical agents, right? So I think right now you see a lot of one-to-one care, like you may have a family doctor caring for one patient. I think you're going to see a lot more like asynchronous care, leveraging agents in the future, where a patient may interact with an AI agent on behalf of let's say a family doctor virtually, and then only get escalated to the human physician for something that needs a higher level of care. And I think patients will get increasingly comfortable with the idea that, like, hey, there is a human involved in some way, but the human may not be the first line of contact. So the way that often now, whether we like it or not, chatbots are the first form of contact for support in a lot of, industries. And then if you really need them, you get escalated to a human agent. I think the same thing is going to start happening more frequently in healthcare, where there's like a clinician who's managing several different agents, and things will escalate only as needed. It won't happen everywhere, but I think we'll start to see those models actually happen.
Maybe as a concluding, we have 2 minutes left. What gives you optimism, both of you? Let's start with you, Ellyn.
I mean, I think, again, I have a very unique perspective because I've now been having these conversations with leading AI in medicine thinkers. I do see that reimagining happening. I do see people out there that are thinking a great deal about how AI could be used in a way that doesn't just benefit the inside of the system, but does benefit patient care. And that really does excite me greatly. I mean, okay, it's self-interest, but the fact that Ask Ellyn has been now used in 100 countries, it's really, I mean, I'm very grateful for that, and it's a bit overwhelming, but I see this opportunity to really elevate the patient's voice, but also to do it in a protected way, and I hope that there's a future where actually patients aren't going to ChatGPT Health. I'm really looking for that application layer, which has the appropriate guardrails, I could see, wouldn't this be cool to have a healthcare provider specific LLM, not just an open evidence, but one that actually embodies the knowledge of that organization as well. Those are things that kind of get me really excited.
Josh, your perspective?
Yeah, I think my optimism stems from the fact that it's at least for us, it's the Canadian culture in healthcare. We work in both the US and Canada, and I love the partners we work with in both, but Canada's a lot more collaborative. So in the US, you have health systems competing with each other, and increasingly they're going to use AI to probably compete with each other further for patient market share. But in Canada, it's not like that. In Canada, organizations will collaborate more. They're not truly competitive. They're all trying to share and make patient care better. And so I think collaboration between organizations and between providers and patients is core to the culture of healthcare. It makes me optimistic that we're going to make good decisions and really try hard to make this work.
Thank you both so much. This was really a deeply insightful conversation. that highlights to me that AI-enabled care is ultimately not defined by technical capability alone. It's shaped by trust, by workflows, by human need, as well as operational reality. And whether people genuinely find value in it, technologies that reshape care will be the ones that fit into real lives, real workflows, real moments of vulnerability. That's where healthcare, I think, is already changing. So thank you so much for sharing of your time and perspective so generously. Before we close, I'd also like to preview next month's CareNext Collective, which will be our final session before the summer break. We'll be joined by Matt Fisher, Vice President of Business Operations and Technology at MyoVision. Much of the conversation around AI in healthcare today remains focused on tools, what to buy, what to pilot, what to automate. But the organizations that are moving furthest and fastest are asking a much deeper question. What does an organization need to become in order to fully operate in the age of AI? And so MyoVision is one of those organizations. They are rethinking not only technology, but organizational structure, decision-making, hierarchy, and the role of data itself. And while healthcare has always been fundamentally a data business, many health systems still struggle to operationalize data as a strategic asset capable of driving learning, adaptation, and transformation at scale. So this conversation will explore what it actually means to build an AI-ready organization, not just technologically, but culturally, operationally, and structurally. And so I think this will be one of the most important conversations we have had this year, and I truly hope you will join us. Thank you so much again, Ellyn, Josh, and thank you to our audience, and we look forward to seeing you in June. Bye.
Thanks, everyone. Bye.